Erythropoiesis begins in the third week of development, when blood islands appear in the mesoderm around the wall of the yolk sac. Within the center of the blood islands are hemangioblasts, the pluripotent hematopoietic stem cells that will form all future blood cells. Although the first blood cells arise in the yolk sac, this site of blood formation is only temporary. By the sixth week, intra-embryonic hematopoiesis begins to take place in different organs. There is some overlap between periods of erythropoiesis in different organs, so there are often two organs producing blood at the same time. Erythropoiesis occurs in the liver from weeks 6 to 30, the spleen from weeks 9 to 28, and the bone marrow from week 28 onward. Not only is fetal blood produced in different places than in adults, but the hemoglobin is composed of different subunits. Fetal hemoglobin is alpha-2, gamma-2, while adult hemoglobin is alpha-2, beta-2. Do you remember why it is important that they are different? Because fetal hemoglobin has a higher affinity for oxygen, which allows it to pull oxygen out of the maternal blood in the placenta. The switch between the fetal and adult forms of hemoglobin occurs gradually, beginning at 30 weeks gestation, and ultimately results in the fetal form being entirely replaced by the adult form. Oxygen saturation of fetal blood is also lower than in adults, with the blood in the umbilical vein having an oxygen saturation of only 80%. And a final major vascular distinction that is important to know is that fetal circulation is different than that of adults. There are three places where circulation is different. First is the ductus venosus, which carries oxygenated blood from the umbilical vein directly to the inferior vena cava to bypass the hepatic circulation. This closes during the first week of life, and its remnant is called the ligamentum venosum. Second is the foramen ovale, which we already talked about. And the third difference is the ductus arteriosus, which carries partially deoxygenated blood from the pulmonary artery to the lower body. This blood is partially deoxygenated because it already supplied the highest priority organ, which is the developing brain. At birth, the foramen ovale closes and becomes the fossa ovalis, and the ductus arteriosus closes due to the higher oxygen saturation at birth, inhibiting prostaglandin synthesis. Drugs that inhibit prostaglandins, such as indomethacin, will also close a patent ductus arteriosus. This slide is a review of the important fetal structures that are critical in development of the fetus, but are no longer necessary in the adult. We won't go over this again here, but it is important to know the names of the structures in both the fetus and adult, as remnants of the embryological structures can result in pathology. Okay, moving on to the central nervous system. This starts with just three regions: the prosencephalon, mesencephalon, and rhombencephalon, which contribute to the forebrain, midbrain, and hindbrain respectively. The prosencephalon divides into the telencephalon and diencephalon, which become the cerebral hemispheres and thalamus respectively. The rhombencephalon divides into the metencephalon and myeloencephalon, which become the pons and cerebellum and the medulla respectively. The cavities associated with each part of the brain are listed on the right, and these develop along with the rest of the brain. Next, in nervous system development, let's talk about neural tube defects. I mentioned earlier that the neural tube closes during the fourth week, and failure to close can be caused by folate deficiency. This results in a persistent connection between the amniotic cavity and the spinal canal, allowing some proteins to leak out into the amniotic cavity, so you can test for this by looking for alpha-fetoprotein in the amniotic fluid. There are three types of neural tube defects that you should be familiar with for the step 1, as they are commonly tested. We will compare them to this image of a normally developed spinal cord, which is the far left image. Notice how the spinal cord is enclosed within the meninges and dura, which are then completely enclosed in bone. The first neural tube defect is spina bifida occulta, in which the bony spinal canal does not close around the dura, but nothing herniates through this opening and the dura is intact, as you can see in the second image. This is most common in the lower vertebrae and often presents with a tuft of hair growing out of the skin posterior to the lesion. Next is a meningocele, which is similar to spina bifida occulta, but in this case the meninges and dura herniated through the hole in the bone. And lastly, in the far right image is a myelomeningocele, which is the most serious of the three and occurs when the spinal cord also herniates through the bone. These neurotube defects, particularly the ones further to the right in this figure, can cause nerve damage and are most commonly treated surgically either before or after birth. Forebrain anomalies are another type of CNS defect and are much more severe. Anencephaly is a malformation that results in absence of a forebrain, and these babies always die soon after birth. Maternal serum alpha-fetoprotein can be elevated and ultrasound is useful for diagnosis. Holoprosencephaly can be due to dysfunctional Hox genes, which, as we discussed earlier, mediate segmentation during development. This prevents separation of the hemispheres of the brain and is often fatal, but has a wide range of severity, and in some cases can present with almost no signs or symptoms. Other common signs involve merging of paired organs, which can result in cyclopia. Holoprosencephaly is associated with Patau syndrome, severe fetal alcohol syndrome, and a cleft lip or palate. Moving back from the forebrain, let's go over the important posterior fossa malformation. Chiari type 2 malformation is when the cerebellar tonsils herniate through the foramen magnum. This puts increased pressure on the cerebral aqueduct, causing aqueductal stenosis, which blocks flow of cerebral spinal fluid, which in turn causes hydrocephaly. This often presents with a thoracolumbar myelomeningocele, which we just discussed, and can also cause syringomyelia, which we'll discuss more on the next slide, but is basically a buildup of CSF in the spinal canal that can dissect into the white matter of the spinal cord and cause nerve damage. Dandy-Walker is another posterior fossa malformation and is defined by having a large posterior fossa and absent cerebellar vermis with cystic enlargement of the fourth ventricle. This can also lead to hydrocephalus and spina bifida. You'll learn more about this condition in the neurology lectures. Let's go into more depth with syringomyelia. As I mentioned before, it is when CSF builds up in the spinal cord and causes damage. To remember this, look at the beginning of the word syringomyelia, which looks like the word syringe, and think of someone using a syringe to inject CSF into the spinal cord. This most commonly occurs at the C8 and T1 region, and the nerves of the spinal thalamic tract are typically the first to be damaged, which causes bilateral loss of pain and temperature sensation in a cape-like distribution over the shoulders, neck, arms, and back. Importantly, motor control and touch are not affected. This image is what syringomyelia looks like on an MRI. Notice the wide column of CSF.